Myself, Dr. Pallavi Mahajan. I am Assistant Professor of Cardiology at UNMICRC Institute of Cardiology and Research Center. My topic is radiation safety in Cath Lab. What shall we discuss in today's presentation is quick ABC of the X-rays, radiation hazards and monitoring, radiation safety basics, optimizing the radiation safety in Cath labs. We have different type of radiations: alpha, beta, gamma, X-rays and neutron rays. They have a different penetrating capacities. Alpha rays, they can penetrate as thin as paper. Beta, they can penetrate thin boards such as aluminium. Gamma and X, they can penetrate thick boards such as lead. Neutron rays, they can penetrate water and concrete, etc. While penetrating, patient, it loses the intensity. Part of it scatters and small amount reach the flat detector. The collimator reshapes the X-ray beam again towards the patient. Detector entrance dose is measured and feedback is given back to the system. Beam of electrons, they are produced by thermonic emission from heated cathode. X-ray is produced when high energy electrons hit the metal target. Again, the system calculates and regulates the dose by controlling the generator. There are three outcomes when X-ray traverses the tissue. Either it can be a complete penetration, or there can be total absorption, or it can be a scattered interaction. Sources of the radiation in Cath lab: primary and secondary. Primary is most useful for image creation. It is most hazardous to the patient. It is being emitted by X-ray tube to image intensifier. Secondary, it is most hazardous to health worker. It is synonym scattered. It is scattered by object in the route of primary radiation. Only 1% of X-ray penetrate and produce the image. Leakage radiation, it is that penetrated the leader X-ray tube housing. It is a quality control issue. Radiation has got various effects: biological, deterministic and stochastic effect. It is predictable deterministic with a threshold dose. There is no damage below threshold. Above threshold, the probability of injury increases with the dose. Relatively high dose threshold is more than 50 rads, that is 500 millisievert. Skin effects can be in the form of erythema, necrosis and cataract. Stochastic effects, likelihood increase with the dose. No identifiable threshold above which it occurs. Probably in nature, and it is cumulative in nature. Likelihood increase with DAP. Effects like cancer and genetic related defects, it can occur with stochastic effects. Deterministic effects occur in the form of desquamation. It is at a month in a patient receiving 11 gyre calculated peak skin dose. Skin necrosis at 6 months in a patient who received 18 gyre calculated peak skin dose. It has been studied in one paper published in Neurointervention 2012 that brain tumors are very common among interventional cardiologists. That's a cause of alarm. Mostly 87% is left-sided and 14% are right-sided in nature. Radiation in cardiology, we can't live without it. Our exposure today is not felt today. It may be felt for years to come. Radiation-induced cancers, they have a biological latency period of more than 10 years. When does a cancer develop in interventional cardiologist? It has got latent period of years. Like leukemia, minimum latent period is of 2 to 4 years and maximum it is of 10 to 20 years. For solid cancers, minimum latent period is of 10 years and maximum it is of 30 to 40 years. Bad backs, aching aches, they are the occupational hazards which we usually encounter. Radiation monitoring basics. How do we monitor the radiation? So we have various radiological units. Customary unit is Rogenton. SI unit is Gray. Air Karma what is air karma? It is a kinetic energy which is being delivered to air. Symbol is air karma at interventional reference point. We all see it is displayed in monitor in milligray, associated with deterministic effects. Again, we have absorbed dose, which is calculated. Customary unit, we have radiation absorbed dose, and SI unit, we have gray. 1 gray is equivalent to 100 rads, and 1 gray is equivalent to 1 joule of energy delivered per kg mass. Effective dose or biological dose, we have the units customary unit, rem, and SI unit, sievert. 1 sievert is equivalent to 100 rem. Radiological units are also displayed in the form of DAP and CAP, that is karma air products. It is the total amount of X-ray which is leaving the tube. It is absorbed dose multiplied by the irradiated area. It monitors the patient dose burden. It is a better indicator of stochastic effect. Skin dose can be calculated with cap and field size. We should know what displays on our screen. Exposure 30 frame per second. Fluoro time, it does not consider cine, patient size and angulation. Air karma, it is displayed in the form of milligray and it is associated with deterministic effect. However, DAP and CAP, they are displayed in milligrays per centimeter square. It is a better indicator of stochastic effect. Skin dose can be calculated with cap and field size. Personal monitoring is very important and we need to have TLD batches, thermolucent dosimetry. Position where we can place these TLD batches, it is on the chest, behind the aprons, front of apron, on the ring and in the eye. How much dose is safe for an interventional cardiologist? Acceptable limits for a physician is 2 to 50 millisievert per year. For nurses, it is 8 to 16 millisievert per year. For technicians, it is 2 millisievert per year. We do not have to exceed more than 50 millisievert in 1 calendar year. And cumulative maximum exposure limits is in 5 years it is less than 100 millisievert in 5 years, and all lifetime it is less than 10 millisievert into age. For pregnant women, less than 5 millisievert during pregnancy. Radiation protection basics. We have 3 tenets for radiation protection basis. First is justifiable exposure. The benefit of the radiation should outweigh its harm. Second is ALARA. As low as reasonably achievable should be our aim. So we have a TDS principle for that. Dose limits. Exposure should be within the prescribed dose. ALARA versus NIWID. ALARA is as low as reasonably achievable versus NIWD is we don't have any idea what we are doing. So ALARA has 3 basic tenets, that is TDS. Time, less time should be spent near the source. D, greater is the distance from the source, less is the radiation we are receiving. And S is the shielding. Behind shielding from source, less radiation is received. What are the sources of radiation? Patient, X-ray tube, secondary in the form of scattered radiation arising from the patient. So scattered radiation is proportional to the patient dose. Another is the leakage radiation that penetrated the leaded X-ray tubing housing. Who is the cause of radiation? Definitely the operator. Thou shalt kick less. All radiation in the room is caused by the operator. So we have to plan the procedure to reduce the time. Finish all your work that can be done under fluoroscopy. Use last image hold and fluoro replay to reduce the lifetime. Don't press the foot paddle unnecessarily unless your eyes they are on the screen. Avoid pressing when the staff is very close to the patient or back exposed. Avoid unnecessary presence in the lab. Thou shalt stay away from X-ray. So more is the distance, doubling is the distance from the source, reducing the dose by 4 times. Stay away from the radiation. Stay away from the patient. Twice the distance you are away, one-fourth is the scattered radiation. So move away from the patient when you can. Example, during the contrast injection. Step away from the beam entry point when you can't move away. Stay away, hands off. Don't put the hands in the beam. If the hands have to be there, position the patient's body between the beam and your hand. Staff can stay close to the walls. Exposure near the walls is insignificant. Distance is the safety factor over which the staff and the team have a greater personal control. When the staff is very close to the patient, don't switch on. Thou shalt filter. Make the optimum use of filters, and copper filters are more protective as compared to aluminium one. Low energy, copper one, they have a low energy photons and they can reduce the skin dose by almost 70%. Use of proper filters, they can reduce the dose. Filtering will prevent the image saturation in low absorption areas. Thou shalt collimate. Confine the beam to the active area of interest. Image contrast improved as less scattered reach the area of interest. So almost collimation reduce the dose by 25%. Do virtual collimation on last image hold. Collimate by using the wedge filters. When the wedge filters are used, the radiation dosage also reduces. Advanced collimation, that is spot fluoroscopy. This is the new technique in which we can customize our area of interest. So we can apply only fluoro there where we have a specific interest. Thou shalt shield. Self, staff, patient. A is for thyroid collar, B is TLD batches, C proper radiation goggles, D radiation face shield, E is for radiation waist and upper lid and chest, F is gonadal shielders. Thou shalt shield. This is the nylon fabric across the table for double wrap. It has to be 24 inches and W is in the form of each individual strip is 4.5 inches. Other personal safety accessories what we can use is radiation gloves, radiation goggles, gonadal shield, radiation caps, when we have a radiation boots what we can use. Ceiling mounted lead glass. The average eye dose per interventional procedure with the lead screen is 170 millisievert. However, without lead glass screen, we are exposed to 439 millisievert. So almost there is 50% reduction in dose saving if you are using proper ceiling mounted lead glass. Thou shalt shield. Positioning of the patient is very important. Hand should be placed above the head. Thou shalt optimize the fluoroscopy. We should know your machine. So DSA is equivalent to 10 times the cine. Cine is 10 times more dose exposure than fluoro, and 100 fluoro frames is equivalent to 10 cine frame is equivalent to 1 DSC frame. So use last image hold, use fluorostore, use pulse fluoroscopy, use low frame rate. Pulse fluoro versus continuous fluoro. Patient dose what is being exposed with fluoroscopy, pulse fluoroscopy is 0.08 millisievert per minute for 3 frames per second, 0.11 millisievert per minute for 7.5 frame per second, 0.18 millisievert per minute for 15 frame per second. In case of continuous fluoroscopy, we are being exposed to 0.44 millisievert per minute. Thou shalt don't use the steep angles. Use shallow angles as much as possible. For every 3 centimeter patient thickness, entrance dose is doubled. So shallow angle, less air karma. Thou shalt do not use the steep angles, as the steep angles they use the shortest route. So it has been seen reducing the LAO from 45 to 30 degree, it reduced the radiation dose by 35% in one study. Which angle gives the less radiation? It is LAO 55 and cranial 25. Tube angulations are very important for optimizing the radiation. Employ caudal views RAO rather than LAO caudal views. RAO 10 30 instead of LAO 60 0. It reduces the operator dose by 75%. Employ LAO 30 0 degree over LAO 45 0 degree. This is the angulation when we have to see the left circumflex and RCA. Almost 43% reduction in the dosage is seen. A panoramic lateral RAO 90 degree 0 degree view of LAD involves a significant radiation benefits over LAO 90 degree 0 degree projection. LAO views more than 60 degree with cranial and caudal angulation more than 20 degrees are unjustifiable. They have high radiation dose to the patient as well as to the staff. Thou shalt mind the geometry. Keep the detector close to the patient. It reduces the scattered, improve the image clarity. In first figure, we see the detector is placed close to the patient. It reduces the scattered and improve the image clarity. In second image, we see keep the detector close to the patient and raise the table close to the detector. It lowers the dose close to the patient. So in first position, large distance is there between the patient and detector. So high dose is there. So in second position, small distance is there between the patient and the detector. So low dose is being received. Mind the geometry. Inverse square law. Increase the distance by 2 times, dose will come down by 4 times. Increase the distance by 3 times, dose will come down by 9 times. So to reduce the skin dose, keep the patient away from the tube, bring the detector close to the patient. Thou shalt do not zoom. So for small field of views, higher magnification, it requires the higher dose than the larger field of views. Thou shalt train your staff. The aim should be to optimize the patient dose and to minimize the staff dose. Aim should not be to minimize the patient dose and minimize the staff dose. Carry home messages, collimate well, use filters, move away from the patient and tube. Keep the detector as close to the patient and tube away from the patient. Avoid magnification. Know your machine. Avoid foot paddle syndrome. Avoid steep angulation. Shield yourself as well as patient. Train your staff. Take home messages to reduce for patient and for the operator. Use intermittent fluoroscopy. Avoid heavy foot pedal. Reduce the frame rate. Use pulse fluoro rather than continuous fluoro. 20% reduction with 30 frame rates and 80% reduction with 50 frame rates. Use automatic dose adjustment to limit your KVP and MA. Reduce X-ray grid wherever possible. Avoid cine, use fluorosafe. Avoid steep angles. Minimize the magnification modes. Do not reduce the field of view. Keep image intensifier close to the patient. Low subject image distance. Collimate to the fullest extent. Plan the virtual collimation and use last image hold. Monitor radiation dose in real time. Take home message primarily for the operator is use appropriate protective garments in the form of radiation caps, goggles, thyroid protectors, gonadal shields, then waist, the upper chest and the lower waist skirt, Then we have radiation gloves also, radiation boots also. So we have to optimize, we have to make use of the radiation protective agents as much as possible. Maximize the distance of operator from the patient, stay away from the patient, stay away from the source. Use above table and below table protective shields. Keep the operator body out of field of view at all the times. Consider robotic procedures. Keep monitor close to the operator. Optimal operator to monitor distance should be 1 meter or less. Primarily for the patients, change the image beam angle periodically to minimize the exposure. Keep the patient extremities out of beam. Keep table as high as possible and comfortable to the operator. Thank you.